Sure.
So I think yes, we're good. Okay, so guys, we're here. I'm Dr. Pete, and I'm here today with Dr. Kesava Kovanur Sampath. We'll call him Kesava going forward. He prefers to be called that. Thank you for being on the podcast, Kesava. And I wanted to, the purpose of this, my chat with you is to get some of this information about the really amazing research you're doing, not only for chiropractors who may be listening, but also for their patients of chiropractors. So we'll try to, bridge those two, and there's slightly different terminologies and things, but
Sure.
you are at in Christchurch, and what is the name of the university you do your research at?
Sure. Firstly, thank you, Dr. Peter. Thanks for taking your valuable time from clinical practice. And I'm really thrilled and honored to be part of your podcast. Before I go into my research, I would quickly tell you a bit about my background. That's okay. Yeah. So I initially trained as a physiotherapist.
Okay.
This was back in India. And a few years in clinical practice, I wanted to be more hands-on, incorporating more manual therapy into my practice, which led me to move to New Zealand, where I trained as an osteopath at Auckland. And 5 years down the line, I started really getting interested into research. So I did my PhD at University of Otago in Dunedin in South Island. I finished that 2 years back, and at the minute I'm working as a lecturer teaching at the undergrad program at ARA Institute of Canterbury in Christchurch.
Great. And that school, you're teaching physiotherapists or osteopaths, or?
No, I'm teaching the osteopaths.
Okay, excellent, very good. Yeah. So as far as the we'll get into the research, but did you have any personal experiences yourself with osteopathy or hands-on treatment that got you interested in this field?
That's correct. So when I trained as a physiotherapist, it was the last day. You finish your exams, you're probably a bunch of 21-year-olds. So we went out, had fun. It was a beautiful day back in India, nice sunny weather in the beach. So we were like 10 kids playing at the beach, and we were trying to do some somersaults in the beach. And unfortunately, I did a really wrong one, and I fractured my C5. Wow. At that minute, they misdiagnosed it. They actually missed a fracture at C5. And I had been to a lot of physios, and I had a lot of rehab. But for 8-9 months, I still had a lot of numbness in my right hand. I couldn't use my right hand. When I was by accident met this osteopath at a conference of all places, and we were just talking like this, and he was the first person to actually put his hands on my neck and do a proper assessment. And that was quite emotionally relieving, because you have seen a lot of practitioners who are like, oh yeah, it's a fracture, needs time. But there's someone who can actually confidently touch. And all he did was probably some sort of traction at C5, C6. And after 8 months, to be honest, I could get the sensation back in my right hand. Wow. It was unbelievable. Even when I talk about it right now, I still get emotional with people when I say this, because it was horrible to be in pain and numbness for 8 months. So this was a really kind of a turning point in me personally wanting to pursue more hands-on treatment. Yeah, so that's where the journey started. And because, as it happened, he was an osteopath, I went into osteopathy.
Fantastic.
Yeah.
I'll share a bit of my background because it's relevant to the conversation. Some of the viewers may be aware, but I similarly had a positive experience with we're in North America, and whether we call it spinal adjusting or spinal manipulation. I had I had gone to a chiropractor, and I had some results with things that people don't normally associate. So I had a very I used to be a police officer, actually.
Right.
Yeah. So, when I was doing that job, I got very sick with mononucleosis.
Oh, wow. Yeah.
I was exhausted all the time and just get back going, recovering. And once I started under the care of a chiropractor, my levels came up, and my headaches went away, and my digestion improved. And
Wow.
the chiropractor explained to me, well, you know, these changes are because when we're doing this, when we're doing something to your spine, it's affecting your nerve system. And I thought
Sure.
really that was great. And I showed, you know, he showed the nerve chart and it made sense. As I went and became a chiropractor and have gone out in the community, you know,
Yep.
it's a message that a lot of people just have a hard time understanding. You're going to push on somebody's back and it's going to affect something in their body. How does that work? And even academics and researchers and physicians sometimes, you know, don't understand that link. So
No, no. That's fantastic story. It's that really ties in a lot of patient population that actually come to see an osteopath or a chiropractor, basically because they've had some really good clinical outcomes, and it's not just on their pain or a physical fitness or a muscle soreness. So that's outstanding, Peter. That's great to know.
yeah,
Similar experience.
yeah. It's, so my passion is to bring this information to people, and they can choose to use it how they wish. And so
Sure.
I go on to you know, Google Scholar occasionally, and I came across your paper in Medical Hypotheses, and the title Measurable Changes in the Neuroendocrine Mechanism Following Spinal Manipulation. So I wanted to get into that and really talk about because as I mentioned to you before we got started here, I haven't really seen anybody, certainly in North America, any papers or labs that are doing this type of work. And because most of the research on spinal manipulation focuses on things like, you know, chronic low back pain and such things. So can you tell us about sort of how you got into studying that and what your initial findings are indicating?
Sure. So this research actually started following a very casual sort of a conversation in clinical practice when I had this patient who was he was an academic himself. So he was really very cerebral, and he would ask me a lot of questions. So I was, you know, he had neck pain, chronic neck pains. I was adjusting his thoracic spine, and he threw up this question of, well, my pain has been in the neck, especially in the upper neck. And why are you adjusting what are you doing in my upper back? So I started to explain him, and, you know, we train with the biomechanical paradigm. So you start to tell them the link between the muscles and the anatomy and how this interconnects with the neck and things like that. But he actually opened this sort of a curiosity in me as to saying, okay, I I know there is a biomechanical connection here, but is there anything more that's going on, which actually I'm as a clinician missing? So then I went into Google Scholar and started doing I've been interested in research all the way along. So I bumped on a paper by Biolowski et al., which is they proposed a comprehensive model for manual therapy, not spinal manipulation per se. But that was a really interesting paper to read. And then I noticed that actually they've kind of ignored the endocrine mechanisms. And as you said, often the physiological studies are based on the autonomic nervous system. So there has been a lot of studies done on what happens in the sympathetic nervous system or the parasympathetic nervous system, and studies have been utilizing skin conduction or heart rate variability to measure the ANS response pre and post. But when you look at the complex interplay of the physiological systems, you can't ignore the fact that the autonomic nervous system and the endocrine system, they cross communicate, and there is a cross linkage between these two systems, and we can't ignore one system and measure the other. And that was the hypothesis that we actually proposed, saying if a sensory input, for example, spinal manipulation, and there is some imaging studies that has been done that shows the signals end up in different parts of the brain, through which we have a reduced pain or reduced anxiety, for example, then they should reach the part of the brain which control the endocrine mechanisms as well. So then we hypothesized that we should be able to measure these changes, and that's what we did in the lab. The first study was a pilot study where we took 24 men, and we chose only men because we measured testosterone and cortisol. I will give you a bit of a background on why we did both hormones and not just the one in a minute. And so we measured both the hormones and also heart rate variability to see if we can see changes in both the systems like we proposed. And the initial study, the findings from the pilot study were quite interesting. We did see changes in testosterone to cortisol ratio, which so traditionally studies have measured cortisol, which we know is a hormone which is released under stress, and the studies have argued that if there is any changes in cortisol, then we should have influenced the hypothalamic-pituitary-adrenal axis, or in short HPA axis. But in the last 5 to 10 years, science studies have shown that the HPA axis doesn't just work on its own. so they all talk with each other. As much as we want to take a Descartesian route and say, I'm going to just measure this and I'm going to stick with this, but that doesn't actually happen within the physiology of the body. So the hypothalamic-pituitary-adrenal axis has a lot of cross communication with the hypothalamic-pituitary-gonadal axis, which results in the secretion of either testosterone in male or estrogen in females. And we also know from clinical practice that there is a wide difference in between the genders in terms of why females are a bit more prone for something and why males are prone for a few other things.
Yeah.
We said, so in the last 5 years, scientific studies have moved away from measuring just cortisol. They actually measure both testosterone and cortisol and create a ratio which we call a TC ratio, which is the ratio between testosterone and cortisol. So one of our main strengths in terms of advancing the profession is measuring using TC ratio as a measure. So with our pilot study that we did on 24 men, and we chose men because it's easy to measure testosterone in men, and because it's a pilot study, we wanted to keep it nice and tight, well controlled. We actually saw good changes in TC ratio, and interestingly, it was not a short-term response. Often studies have measured their outcome measure immediately after manipulation. So traditionally, you would have seen studies reporting, oh, we saw changes 30 minutes after manipulation, or maximum an hour or 2 hours after manipulation. But we said, clinically, often you would see patients saying, I felt a bit sore for a few hours, but then I started getting better the next morning. So we said, probably we should measure 6 hours down the line to see what happens at 6 hours after a minute. And very interestingly, we saw statistically significant changes in TC ratio after a thoracic manipulation. And that's just a one-off manipulation. So we were not expecting to actually see changes. We were just doing the pilot study to kind of make our methodology robust for future studies. So when we saw these changes, we were quite excited. And then the next study we carried on, and we had to do that in a clinical population, which is that manuscript is under review in a journal at the minute. So
wait to read it.
Hopefully won't be long. Hopefully the journal likes it, and won't be long that study gets published soon. But what we saw in the next study was even more exciting, that we could actually see changes in both the TC ratio and oxygenated hemoglobin, which is an outcome measure for sympathetic changes within skeletal muscles. So going back to the hypothesis, which we proposed 4 or 5 years back, we actually have some scientific justification for the hypothesis. So we're quite excited at the moment.
That is very exciting. What journal have you submitted? Can you tell me? I don't know if you can tell me what journal you submitted.
Yeah, I can definitely tell you the journal. It's Journal of Manipulative and Physiological Therapeutics, which is a key chiropractic journal, I think.
Chiropractic journal, yeah, that's fantastic. Wow. When you say, I got the questions are building up in my head.
Sure. Please, easy questions.
When you say that second study was done in a clinical population, is that someone with particular symptomatology or?
Correct. So we had certain criteria. So what we didn't want to do is choose a population with spinal pain, for example, neck pain or lower back pain, purely because we know that there is a segmental response from a manipulation.
Yes.
And chronic lower back pain has been studied a lot.
Really has, yeah.
It has been. So we wanted to, because we are teasing out a systemic response, we wanted the symptomatic area to be far away from the spine. So we chose people with Achilles tendinopathy and measured their calf muscle blood flow, which is pretty much what we did with the pilot study too. Okay. It's just that the response was better in a clinical population. People with Achilles tendinopathy, we did see changes in their blood flow, which we didn't in the LT population.
So and now the way we've or the way you've sort of talked about these findings, clinicians and researchers will understand what you're talking about. But to my patients in chiropractic or osteopathic patients listening, I know you don't have all of the conclusions available, but for instance, a change in the testosterone cortisol ratio, what could that mean to a patient or to a person?
Oh, well, that's a really good question. It means quite a lot of things depending on the context. TC ratio has been widely used in various settings. One of the settings that's been used popularly is sports and exercise science. So people with sports injuries like Achilles tendinopathy, which is a sports injury or a repetitive strain injury. And also with all the research that has been done in the last 6 to 8 years, what we can safely say about TC ratio is an increase in TC ratio is generally good for your overall well-being.
Right.
Because we know cortisol is a stress hormone, it's released when we are under stress. So naturally, if the TC ratio has to go up, there are two options. One, either the testosterone is going up or the cortisol is dropping down. So we won't get into the nitty-gritties of that. That's beyond, I think, the scope of this conversation.
Sure.
But generally, a reduce in cortisol is actually good in terms of anxiety, stress, pain, and even with digestion, things like lack of sleep, fatigue. We know cortisol has a huge influence on various systems. So in terms of patients listening to this conversation, what can I say safely at the minute? We all understand that we need more research before we can say this works or this doesn't work, you should be doing this or you shouldn't be doing this. With the kind of preliminary research we have done over the last 5 years, what we can safely say is it's more than just a click that you get from a chiropractor or an osteopath. There are various things, various mechanisms that we are influencing through the click. So probably increase in TC ratio from a spinal manipulation probably is better for their overall well-being.
And for me, a lot of the exciting part of this, Kesava, is that it explains a lot of the clinical, things we will see in practice. Because a lot of the people that come to me here in Canada, they're coming with back pain or neck pain or headaches or numbness and tingling. And and the main, at least in my office, the main sort of modality is spinal adjusting or manipulation.
Sure.
They'll come back to me. Sometimes it's very early on in the care, and sometimes it's later. And they'll how their digestion has improved, their sleep is better. Some people perceive their immune system to function better.
Yeah.
And other people feel they have less anxiety, overall well-being, and it's really. So we know there's something happening, but to research, I love it because it's starting to get to the mechanisms of how this is happening, which is information you can share with, again, patients or practitioners or people in other healthcare disciplines, so they can understand the value of this type of work. So that's why I think it's wonderful what you're doing for where the chiropractic and osteopathy and these professions go. So
surely. And just talking about the various effects that you just mentioned in terms of immune system and better sleep and things like that, there has been ongoing research over the last 15 years. And when I started my own research 5 years back, I was really amazed by some of the works done by the chiropractors, especially in Canada. There is I always struggle with with his or her name, so I'm really sorry if I get the name wrong. Theo Dorsic Injayan
Yes.
et al. At the Canadian Memorial Chiropractic College.
Which is the school, that's the school I went to in Toronto.
Oh, awesome! So, so you might know some of them in the team, and me they've done some outstanding research, which is noteworthy to make in this conversation, because they have done a series of studies where they've measured some immune markers, and what happens with those immune markers before and after intervention. And some of these findings are really, really good and might explain objectively why some people feel better and have better sleep or reduced anxiety. And we know that the immune system and inflammation and stress, they're all a different facet probably of the same thing. So we could make a bit of a correlation saying if the immune system is responding or it's getting better, then you should have a bit of a reduced inflammation. People automatically should feel slightly less stressed, and probably subjectively they're feeling better too because they're feeling less stressed. And that could explain why some patients come to us and say, you know what, Kesava, I've slept like a log after a long time.
Yeah.
And like you rightly said, often these are subjectively based outcome measures or patient testimonies, which unfortunately scientifically it's not rigorous enough to be accepted. But on the other hand, we can't ignore these patient testimonies either, because they are not here to please us. They are here for a treatment, and often patients are your reality checks. And often in New Zealand, patients would be very, they're often what they say would be true. They might come back and say, or sometimes they might tell you, oh, I'm not feeling good. They might be grumpy, or often they would, highly likely they would say, if they're feeling better, you can kind of say probably they are feeling better. So what's interesting for me to see is the manual therapy professions. I'm not getting specifically into chiropractic or osteopathy or physiotherapy, but overall, there has been some really good research in manual therapy that have taken research to the next step, and they've started to explore these objective mechanisms, which I think is really crucial. In 5 to 10 years, it'll be good to provide justifications as to they're feeling better because of this and this, which is more an objective way of looking at it.
Absolutely.
Yeah.
And again, that's and it's again, that's why I appreciate your work, and even what you, going back to that last study, how you mentioned that there's the non-local aspect of it, because that's another thing that patients will find fascinating. They they may have, again, knee pain or plantar fasciitis, and all they do to them is a cervical manipulation or adjustment, and they get a change. And so how do we explain that? Well, we have, is it blood flow? Is it changes in muscle tone, postural muscle, but it's all mediated through the nervous system, of course, which I always tell my patients that, because I want them to understand that, the clicking of their spine, well, what does it really mean? Well, it means we put an input into the nervous system, and and you could probably talk to this briefly, but I do yoga, and the last past year I've been doing yoga, and I really love it, and I feel amazing. Flexibility is good, but there's something different about yoga and getting a chiropractic adjustment or a manipulation, and I believe it's the population of mechanoreceptors and proprioceptors that are triggered in an adjustment is different than when someone is doing stretching or yoga. Can you talk a little bit about that?
Surely, I think it again comes back to the nature of the sensory input that's being put into the nervous system. And also we are talking about, I think, two different contexts. The context is really important. So if someone comes to see me, they have a reason to come and see me. Probably they're in pain, they're in stiffness. And as much as we talk about the therapeutic outcomes, it's also really important to keep in mind a possible placebo effect.
Of course.
And yes. And that's been a bit of a double-edged sword in terms of manual therapy professions. Would you factor in the placebo effect, or would you ignore the placebo effect? And there are two different school of thoughts saying, whenever there is a significant change after an intervention, often some people would ignore it because they just say, oh, it's a placebo effect. But the placebo effect is a really important component for what we do. We need to start incorporating the placebo effect. And I think when people are in pain and they're expecting a therapy done to them, then placebo effect is actually really important component of that outcome. So, and the input as a chiropractic adjustment in that context would play a huge role in how they feel better. Whereas a yoga, for example, it's a slow stretch response, and you incorporate a lot of breathing, and there is a respiration that keys into the vagal mechanisms, and there is a parasympathetic response. So we are talking about, I think, two different things. However, the neurophysiology might be same. The way we are doing it probably is different. And I would hypothesize that the sensory input on these two would probably result in a different neurophysiological response, but probably that might be a good study to do in the future.
It might, and certainly, and that's what I try to tell my patients as well. Is there's room for everything. So,
correct.
You can be getting chiropractic adjustments and doing yoga, meditating. Because they're all, even though they're accessing the nervous system in similar or slightly different angles, they all have potentially positive benefit that can add to your well-being. And I think today, I'm as I go through my life, I'm in my 45 years old. I think the longer I go through life, the more I understand for myself and others that our health and our well-being is really our greatest asset. So to be able to get up in the morning and feel good and go to bed at night and sleep well, it's invaluable, right? And a lot of people here, they may be successful in other ways, but they're missing that well-being, and that's what they're wanting to find.
Exactly, it's a really good point that you just mentioned, Pete. Health and well-being is should be the topmost priority, and it's great to see or great to hear that often you do come across, again, there are two school of thoughts in clinical practice. People just do adjustment or manual therapy, and that's it. And then there are other practitioners who are like, okay, I'm going to do some adjustments, I'm going to work on your muscle, do some muscle energy techniques, but then importantly, they tend to make their patients more active. So you suggest them doing yoga or exercise or whatever it is, and that's really, I think, personally, that's a great way to treat people. It's complete rehabilitation, taking in mind the health and well-being of that person, and not going into that aspect of, okay, this is just a lower back pain that I'm interested in. It's not about the pain or the stiffness. It's about the person that walks through your clinical practice. So it's great to hear that you personally do yoga, because research also shows from a different angle that the practitioner's assumptions would as a say in the clinical outcome of the patients. So if I believe that I have lower back pain and I should be lying down in the bed, which is a myth, I as a practitioner, that's what I would be selling to my patients, and probably that's not right. So we all understand the importance of being active and an active lifestyle. So it's great to hear that that's what you do. That's awesome.
Well, and it is. I find it comical because sometimes you'll get patients come in and say, and I try to tell them gently that healthcare is not a black and white science. It's gray. And, what should I do? What should I not do? Well, it depends. And even if the research says something, is that, well, one thing that I'm really big with patients is looking at what's their value system. So I don't know if it's all practitioners, but myself, I happen to meet a lot of patients that one of their values is to avoid medications if they can.
Right.
On medications if they can avoid it. And what can I do, doc, so that I do not have to, I don't need this pain medication, or I don't need this medication, and sort of guiding and coaching them, which always takes time. But, in 6 months, a year, they can be in a much different state, health-wise, physically, with slow changes. And it's also in ways that are fitting with what their health and life values are, basically.
Sure. Yeah. That's great.
Yeah, well, this has been a great conversation. I'm going to wrap it up in a minute. I know our time, I'm talking to you, and it's 7:30 p.m. and your time, your lunchtime in 7:30 p.m. on the Eastern time zone in Canada and the U.S. But I think we should do a follow-up interview down the road. But I'll leave it with this. What are so you've got this study in publication. What's the next thing that you're going to look at in your line of research? The next step or the next study, if you could share with our listeners.
Surely. So I have quite a bit of varied research interests. So as I started researching, I understand it's pain is the main thing that feeds me. But pain is a multi-dimensional experience. So what we've been investigating is the mechanisms of how spinal manipulation works. But I also, in the next 2 to 3 years, would be investigating on the multidimensional experience of pain. Of course, following on what we've been building on in the last 4 to 5 years, we are intending to measure some immune markers and inflammatory markers, as well as patient-reported outcome measures such as pain and physical fitness or physical function, and see if there is a correlation between TC ratio and the immune markers and or inflammatory markers on one end, which are objective markers. On the other end, we can have the pain and physical function that's been subjectively reported by patients and see if there's a correlation. For example, if the immune markers get better and the patient also subjectively feels better, or what's happening there.
Right.
So that's the next follow-up study. And also we would like to kind of replicate clinical practice, because at the end of the day, all the research we are trying to do is to inform clinical practice. Absolutely. So with some professions, especially osteopathy and physiotherapy, the session tends to be not just spinal manipulation, but a combination of massage or stretching and mobilization, and then a spinal manipulation followed on with some exercises. So we are kind of interested in seeing or comparing what happens purely with just the manipulation and replication of clinical practice.
Right.
Yeah.
A great study to see what the differences are. That's amazing.
That's right. Yeah.
I just want to sort of wrap up, because I think thank you, because again, I really just to close with the way I started, which is your work is helping to help us understand the results we see in practice and to validate those things from a scientific perspective. And that validation is going to continue in, for another 50, 100 years. We'll be gone, but of our study, but your work is paving the way. So thank you for that. I can't wait to your new paper and in the JMPT, we call it up here, Journal of and Physiological. If there's any chiropractors or researchers that want to get a hold of you, what's the best way for them to find you, if they want to email you or contact you? Or
the email address that you've got would be the best.
I'll link it in when I post this our chat.
Sure.
Okay.
Yeah, sure. And I think it would make sense to have a closer relationship with chiropractors, because this is, I'm doing a lot of investigation on spinal manipulation, and it'll be really good to have more better working relationship, for example. And if there's any research team out there that they're doing similar stuff, then it'll make sense to have a collaborative approach. So we are not doing similar stuff, but at 2 different parts of the world.
Yeah. No, that's a great point. And it's funny because I've shared a few of your papers on some of the Facebook groups, and most of the people in North America were completely unaware of the work that you're doing.
Oh, okay.
More will be aware, and then more class, more.
Sure.
The bottom line being better results for our patients. So.
Yes, that's right.
Okay. Thank you so much, Kesava. And we will chat soon. All right.
Sure. Thanks a lot, Peter. Thanks for this opportunity, and I'm so glad that I had an opportunity to talk to you. So thank you.
No problem. Take care.
You too. Bye.